Hello everyone, I am Dr. Shaw Mukherjee and welcome back to my channel. So in today's video, we'll be going to have a ultra short rapid revision of your subject physiology. We'll be covering physiology in 30 minutes and in 9 pages. So you can revise it just before going to the exam. So let me assume there will be two types of students who will be watching this video. The first category who have already studied physiology once from your main source and you are going to revise it before going to the exam, and the other category of students who are planning to leave the subject physiology, maybe they haven't got time yet to study it, or they may be not getting the proper guidance of how to remember the important points or what to study. So it's enough for those students also. You can refer to this 9 pages PDF and you can revise it at least 3 times before going to the exam, and I can guarantee that you will get at least 10 to 12 questions from this PDF only. Now coming to the other subjects, you can get all the remaining 7 subjects. I have already made the videos. You can get it in my channel. The link for this subject specifically will be given in the comment box. You can download it. You can download the PDF, and the link for that will be given in the comment box. And also you can join my Telegram study group where I will be posting daily quizzes and grand tests and also image based questions, and you will also be getting latest updates regarding your FMG and NEET PG exam. So this PDF of physiology is enough for your FMG and NEET PG exam. And let me be very clear, I am giving a disclaimer that this is not for concept building or for proper understanding of physiology to know all the topics, because you don't have such time left to understand everything now. You just have to revise it thoroughly, revise it 3 to 4 times before going to the exam, and you are good to go. It will help you just pass the exam, okay? Because you will get 10 to 12 questions correct from this PDF. So don't have some queries or doubts in your mind that is this PDF enough or not. This PDF is enough to pass your exam. Okay, this is enough to pass your exam. So just focus on the video, make your own notes if you want, or you can download the PDF also. So let's get started. And also one request, please do subscribe to my channel, like the video if you find it useful, and give down your valuable feedback in the comment box. Thank you. Have a good day and watch the video.
Our first topic is general physiology and our first subtopic is transport. So transport is of two types, active transport and passive transport. Active transport means ATP is required and it will be against the gradient. Since it is against the gradient, low to high, therefore we need something to drive it. It requires ATP. Whereas passive transport, no ATP is required and it will be along the gradient, like from high to low. Now, active transport is again of two types, primary and secondary. Primary means if in the question if you get any pumps, that means it is a primary transport. Secondary transport means it requires sodium or iodide, so sodium transport or co-transport. Example is SGLT. SGLT1 is found in our kidney, SGLT1 is found in our GIT, SGLT2 is found in our kidney. Now coming to passive transport. Passive transport is again of two types, simple and facilitated. Simple means no carrier or transporter is required, whereas in facilitated passive transport we use carrier or transporter, and it will be anything except sodium. So without sodium, any transporter, it may be glucose, example glut or aquaporin. So with this we end the topic of transport. Now let's learn some one-liners here. RBCs don't contain mitochondria. So which cells don't contain mitochondria? It is RBCs. Cell membrane model is also known as the fluid mosaic model. Cell membrane component. What is the component of cell membrane? Phospholipid is the most important, most common component. Then comes cholesterol and sphingomyelin. Homeostasis component. What are the components to maintain homeostasis? It requires stimulus, receptor and an effector. So these three things are required to maintain homeostasis environment. Equilibrium potential. Let's learn the equilibrium potential. So equilibrium potential for potassium is minus 93 millivolt. For sodium it is plus 60. For chloride it is minus 70. And for calcium it is plus 120. Now coming to total body water. Total body water constitutes 60% of our body weight, and ICF, intracellular fluid, is 40% of the total body water, whereas ECF, extracellular fluid, is 20% of the total body water. Now very important, what is the dye by which we can measure the total body water? The dye most common is deuterium oxide, then comes tritium oxide, and the other one is antipyrine. And for extracellular fluid, what will be the dyes? Most common one is insulin. We can also use sucrose or mannitol. So these dyes you have to remember, this is important. Okay. Also from active and passive transport you can expect a guaranteed question, maybe at your FMG or NEET PG exam. Now coming to the force generating proteins. So what are the force generating proteins? Dynein, kinesin, myosin and dynamines. These are all force generating proteins. These help in movement. Plasma osmolarity is 285 to 295 milliosmol per liter, and it is mainly due to sodium. So plasma osmolarity is mainly due to sodium, which is 285 to 295 milliosmol per liter. Insensible loss of water through the skin in normal condition is 350 ml, and insensible loss of water through our lungs in normal condition is again 350 ml, whereas through skin and lungs during heavy exercise it will be 650 ml. Now, skeleton and cardiac muscles both are striated and voluntary in function, whereas smooth muscle is non-striated and involuntary in function. What is a sarcomere? Sarcomere is present between the two Z lines. Myosin filament, it is present throughout the A band, and it is immobile during muscle contraction. So myosin filament is immobile during muscle contraction, whereas actin filament slides over the myosin filament during contraction, and it constitutes of three proteins, namely actin, troponin, and tropomyosin. Again, troponin is of three types: trop I, trop C, and trop T, which has various functions. What is the function of tropomyosin? It covers the active sites of actin. Now coming to rheobase. So what is the definition of rheobase? Rheobase is the minimum strength of stimulus which can excite a tissue. So all of you know that a stimulus is needed to excite a tissue. Okay, so what is the minimum strength required? Suppose some strength is required to excite a tissue. At that particular strength only the tissue will be excited. So that is known as rheobase. And what is chronaxia? Chronaxia means the minimum time required to double the rheobase strength. So this is rheobase, and to double the rheobase strength, the time required, the minimum time required, is known as chronaxia. Electrical activity of a muscle is measured by electromyography. With this, we end the topic of general physiology. Now we will move on to excretory system or kidney. So what are the functions of the kidney? Filtration, secretion, and reabsorption. Filtration occurs through glomerulus. Secretion and reabsorption occurs through the tubules, maximum in the proximal convoluted tubule. Now, this is a question, okay? All are maximally reabsorbed in PCT except, so maximum absorption, reabsorption occurs in the proximal convoluted tubule, we have already told you. Now, all substances are maximally reabsorbed in the PCT except, so which substance is not reabsorbed? It is magnesium. All are maximally secreted in the PCT except, so all substances are secreted except potassium and chloride. These two things you have to remember. Now coming back to glomerulus. Glomerulus size is 4 to 8 nanometer pore size, and sialoproteins which are present in the glomerulus, they prevent filtration of negatively charged plasma proteins. What is the formula of clearance? Clearance formula is UV by P, where U means urine concentration, V means urine volume, and P means plasma concentration. So UV by P is the formula of clearance. Clearance is equals to GFR only if filtration takes place. So when is clearance equals to GFR? Clearance and GFR are same if only filtration is taking place. And we can calculate that with, like, the example is inulin, okay, and it is best calculation for GMR estimation. So best calculation for GMR estimation, we can calculate GFR, the accurate, the appropriate one, by using inulin, because the clearance is equals to the glomerular filtration rate. When is clearance more than the GFR? Clearance is more than the GFR if both filtration and secretion are taking place. Example is creatinine or PAH, and it is used for renal plasma flow estimation. When is clearance less than GFR? So clearance is less than GFR if filtration and reabsorption are taking place. Example is glucose, where clearance is 0 and 100% reabsorption is taking place. Now, what are the hormones which are secreted by the kidney? They are renin, thrombopoietin, erythropoietin, and 1,25-dihydroxycholecalciferol. So these are the hormones which are secreted by the kidney. What is the normal GFR? It is 125 ml per minute or 180 liter per day. If it is less than 500 ml per day, so this is normal, 180 liter per day. If it is less than 500 ml per day, it is called oliguria. If it is more than 3 liter per day, it is called polyuria. Glomerular membrane permits the passage of substances which are 4 nanometer in size. So up to 4 nanometer it is permitted to pass through the glomerular membrane, and more than 8 nanometer absolutely stops. Renal blood flow is 25% of the cardiac output. So whatever is our cardiac output, renal blood flow will be 25% of that. And what is the value? 1250 ml, 1250 ml per minute is our renal blood flow, which is 25% of the cardiac output. So multiply it by 4 and you will get our cardiac output. Glucose and amino acids are 100% absorbed in the PCT by secondary active transport. We have already discussed it in the general physiology. And maximum absorption also occurs in the PCT. Acidosis means pH is less than 7.35. Alkalosis means pH is more than 7.45. What is respiratory acidosis? It is the primary excess of carbonic acid. So due to primary excess of carbonic acid, respiratory acidosis occurs, and it occurs due to hypoventilation in respiratory disease and neural diseases. What is metabolic acidosis? It is the primary deficiency of bicarbonate. So if there is deficiency of bicarbonate, it causes metabolic acidosis, and it is seen in lactic acidosis, diabetic ketoacidosis, eudomic acidosis, and diarrhea. What is respiratory acidosis? So sorry, respiratory alkalosis. Okay, this will be alkalosis. So respiratory alkalosis is primary deficiency of carbonic acid, and it is due to hyperventilation in hypoxia. Metabolic alkalosis is due to primary excess of bicarbonate, and it is seen in vomiting and treatment with diuretics. So when you do treatment with diuretics, there may be resultant metabolic alkalosis. So our excretory system or kidney topic is ending with that, and now we will start very important topic, which is respiratory system. So first understand compliance. So what is the compliance of our lungs? It is the stretchability or the expanding capacity of our lungs. What is the formula for compliance? Compliance equals to delta V by delta P, ventilation and perfusion. Increased compliance is found in emphysema, and decreased compliance is found in restrictive lung diseases. Surfactant prevents our lung from collapse or respiratory distress syndrome or hyaline membrane disease. So surfactant prevents our lung from collapse. Okay. How it prevents the lung from collapse? By reducing the surface tension. And surfactant is produced by type 2 pneumocytes. When it is produced the maximum is produced at 35 to 36 weeks, and it is produced by steroids. So in preterm neonates who are born before 35 weeks, less than 32 weeks, okay, so in those neonates, the lungs are not matured properly, and this surfactant is not formed. So they have a chance of developing respiratory distress syndrome or hyaline membrane disease. So what we have to do? Prophylaxis, we have to give betamethasone or dexamethasone to the mother. Antenatally, we can give betamethasone or dexamethasone, which will do the action of steroids. They're all steroids, and it will help in the formation of surfactants. And this can reduce the risk of respiratory distress syndrome or hyaline membrane disease. Now, what is the composition of surfactant? It is lecithin or dipalmitoyl phosphatidylcholine. Also, you can check if the surfactant level is normal or not by checking the lecithin sphygmomyelin ratio. Okay, the ratio should be 2:1. If it is less than 2:1, that means surfactant is not yet developed properly. Now coming to some graphs, this is known as the flow volume curve. Here you can find that this violet one is the normal one. Here we have divided it into expiration and inspiration. It is the flow liter per second, and this is the volume. So if this loop, this is the normal loop, okay, if this loop is shifting towards the right side, the red one, it means there is presence of restrictive lung diseases and volumes are less than normal, and FEV1 and FVC also decrease in proportion. Now look at this green one. If this loop shifts to the left, what does it mean? It means obstructive lung disease, volumes are more than normal, and FEV1 decreases more than FVC. So just remember, if loop shifts to the right, it is obstructive lung disease. If loop shifts to the left, it is obstructive. If to the right, it is restrictive. R for restrictive, right, restrictive. Okay, by this you can remember. Now coming to the Weibull airway classification. So by here you have to remember only these 4 things. These 4 are very, very important. Other things, if you don't remember also, it's okay. Trachea is 0 generation, terminal bronchial is 16 generation, respiratory bronchial is 17 generation, and alveoli is 23rd generation. So these generations may be asked in the questions. Now, as I told you, surfactant is produced by the type 2 pneumocytes here. So in our lungs, we have 2 types of pneumocytes. Type 1, which has the maximum surface area, and it is used for gas exchange, and type 2 pneumocytes, which produce the surfactants, and these are the most abundant ones. Pulmonary alveolar macrophages are the dust cells. Kussmaul's breathing, we can find it in diabetic ketoacidosis. This is again important. Respiratory centers. So during inspiration is controlled by which respiratory center? From the dorsal group of neurons near the tractus solitarius nucleus, and expiration is controlled by the ventral group in the ventral part of the medulla. Okay, so here is another graph of respiration. Here you can find this is the inspiratory reserve volume, this is the tidal volume, this portion, and the below one is the expiratory reserve volume, and the air which is not expired out is known as the residual volume. Expiratory reserve volume and RV together makes FRC, IRV and TV together makes the inspiratory capacity, and these three things together, inspiratory reserve volume, TV and expiratory reserve volume together makes the vital capacity, and everything together it makes the total lung capacity. And we can measure all the lung capacities by using spirometer, whereas spirometer cannot measure RV and TLC. So residual volume and total lung capacity cannot be measured with the help of spirometer. Now coming to the VQ ratio, which is the ventilation perfusion ratio, and it indicates gas exchange. Okay, so if ventilation perfusion ratio is equals to 1, it means it is an ideal ratio and best gas exchange occurs at such point. And if it is not 1, if it is not equals to 1, it means that there is a ventilation perfusion mismatch, and it is due to hypoxic hypoxia, where PaO2 will be less than 60 mmHg. Maximum ventilation perfusion ratio will be at the apex of the lung. Suppose this is the lung, at the apex, this portion there will be maximum, and minimum will be at the base of the lung. Okay, so at the apex of the lung, tuberculosis is the most common. Why? Because ventilation perfusion ratio is the maximum at the apex of the lung, therefore tuberculosis is most common at apex of the lung. Here is another graph. This is the hemoglobin oxygen curve. So this black line you can find, this is a sigmoid shaped curve. Sigmoid means this shape. Okay, so if this curve, if this line, sigmoid shaped line, shifts to the right, if there is a right shift, there is Bode effect. Bode effect means there is release of oxygen to the tissue, and if this shifts to the left, this side, this red dotted line, this means there is left shift, which is a Halden effect, and it occurs in the lungs where oxygen will bind to the hemoglobin. So Bode effect and Halden effect, this question may come. What is the pacemaker of respiration? It is very, very important. It is the pre-Bodzinger complex. Pre-Bodzinger complex is the pacemaker of respiration. Now let's start the cardiovascular system. So what is the pacemaker of our heart? It is SA node, and it is due to, why it is known as the pacemaker? Because due to its maximum frequency. Now coming to cardiac cycle. Cardiac cycle consists of two parts, systole and diastole. S1 to S2 is systole, whereas S2 to S1 is diastole. What happens? Mitral valve and tricuspid valve will close. After mitral valve and tricuspid valve close, there will be isovolumetric contraction. What is isovolumetric contraction? It means, here you can find the definition here. All valves are closed and the ventricle pressure increases. Since all the valves are closed, okay, so these are the mitral and tricuspid valves. So if all the valves are closed, the pressure in the ventricles will increase. This is known as isovolumetric contraction. Now what happens? The aortic and the pulmonary valves will open. Since these valves now open, there will be ejection. So aortic and pulmonary valves open, then there will be ejection. Now at S2, aortic and pulmonary valves close. So S2 sound comes. Now again all the valves are closed and the blood has also ejected out. Now there will be relaxation, isovolumetric relaxation. This occurs in the diastole phase. Now what happens? After isovolumetric relaxation, there will be again opening of mitral valve and tricuspid valves. There will be filling. Filling is of two stages, early and late. If there is early filling, the sound heart will be S3, and in late filling we can hear S4. So this was the cardiac cycle in short. Cardiac cycle is of 0.8 seconds, systole is 0.27 seconds, and diastole comprises 0.53 seconds. So total 0.8 seconds. What is atrial systole? Atrial systole means atria is contracting and small amount of blood is entering the ventricles. Isovolumetric contraction, I already told you, all the valves are closed at this point of time. Therefore, the blood is in the ventricles and the ventricular pressure increases. Why the pressure increases? Because all the valves are closed, the blood cannot eject out. Therefore, the pressure increases. Ejection period means, here I told you ejection. Okay, so what is the ejection period? The aortic and the pulmonary valves open, therefore ventricles contract and blood ejects out. This is known as the ejection period. So cardiac cycle is, we end the cardiac cycle with this. Now coming to the various murmurs. So murmurs, what is murmur? Murmur is any abnormal sound in the heart. So why the sound becomes abnormal? It may be due to two types. Suppose blood is flowing. So when blood flows either through a narrow surface than the normal. Suppose this is the normal surface where the blood flows. Now blood is flowing through it. Now if this area becomes narrow like this, if this area becomes narrow, then the blood will make some abnormal sound. So either the blood is flowing through a narrow surface, or this is the normal route of blood and the blood is not flowing through here but flowing through another surface. That is known as murmur. Okay, so when can we hear murmurs? But in these two conditions, when the blood is flowing through the wrong surface or through a narrow surface. Now murmur is of two types. Systolic, the systolic murmur means we can hear it during the systolic period. Diastolic and continuous or machinery murmur. So systolic murmur examples are tricuspid regurgitation, mitral regurgitation, ventricular septal defect, semilunar valve stenosis, and coarctation of aorta. In such conditions we can hear systolic murmur. When we can hear diastolic murmur, we can hear in arterial regurgitation, pulmonary regurgitation, mitral stenosis, and tricuspid stenosis. And when we can hear continuous or machinery murmur, we can hear in a patent ductus arteriosus. So these things you have to remember because it can come in the question, like which of the following is an example of systolic or diastolic or continuous murmur. What is Bainbridge reflex? It is a venous reflex, and here tachycardic reflex of the right atria. So right atria will beat first. Tachycardic reflex of the right atria is known as the Bainbridge reflex. What is Stokes-Adams syndrome? Stokes-Adams syndrome is repeated fainting attacks associated with complete heart block. So if there are repeated fainting attacks, if the patient is fainting again and again after short interval due to complete heart block, it is known as the Stokes-Adams syndrome. Now, which are the hormones which increases our blood pressure? Adrenaline, noradrenaline, aldosterone, thyroxine, angiotensin, vasopressin or ADH, and serotonin. What are the hormones which decreases our blood pressure? It may be VIP, prostaglandin, histamine, bradykinin, ACH, and atrial natriuretic peptide ANP. So just remember the hormones which increases and decreases our BP. Now coming to JVP, jugular venous pressure. So this is the graph of JVP. What are the various waves? You can find A, C, X, V, and Y. So A means atrial contraction, C is ventricular contraction, X is due to atrial relaxation, V is due to atrial filling, and Y is due to atrial emptying. That is when the tricuspid valve opens. So this is the normal graph or normal wave of JVP. Now, when we will find abnormal JVP? So normal, they will not ask you in the question, they will ask you abnormal. So this was the A wave which was due to atrial contraction. So when the atria contracts properly, we will find this A wave. Now when we will find absent A wave? When the A wave is absent during atrial fibrillation. When we will find Cannon A wave? Cannon A wave means very large A wave during complete heart block. When we will find large A wave? During TS and PS, tricuspid stenosis and pulmonary stenosis. Large C and V wave is found in tricuspid regurgitation and prominent X descent. So this is the X descent. If it is more prominent, it is found in constrictive pericarditis. This is very, very important. Prominent X descent in constrictive pericarditis. What is the end diastolic volume? EDV or end diastolic volume, it is 120 to 130 ml normally, and it is the volume filled in the ventricles at the end of diastole. What is stroke volume? It is the volume pumped per beat, and it is normally 70 to 80 ml. What is end systolic volume? It is end diastolic volume minus stroke volume, and it is normally 40 to 50 ml. What is ejection fraction? It is systolic volume by end diastolic volume, stroke volume by end diastolic volume into 100%. Since it is fraction, it is 100% and it is 65%. Normal is 65%. What is cardiac output? The formula is stroke volume into heart rate. That is, it is the blood pumped per minute by the ventricles. What does Frank-Starling law states? Frank-Starling law states that end diastolic volume is directly proportional to stroke volume. So if there is more blood will be pumped per beat. The more blood comes in, the more blood goes out. That is the Frank-Starling law. And what is the formula for BP? Blood pressure, cardiac output into peripheral resistance, and it is controlled. Blood pressure in our body is controlled by baroreceptors. Where are the baroreceptors present? One is present at the aortic sinus and the other at the carotid sinus. Aortic sinus with the help of 10th nerve and carotid sinus with the help of 9th nerve, they will reduce the BP and reduce the heart rate. So they are the baroreceptors which control our BP. ECG we will study in details in medicine, and in FMGE exam from ECG they don't give you an ECG image. So ECG is not that important, but still for PG exams ECG and INSCT also ECG is important. You can study it from medicine, or I will make a separate video for that. Here you just need to remember ECG is maintained by Einthoven law, where lead 2 equals to lead 1 plus lead 3. Hyperkalemia, we can find tall T wave in the ECG. Hypokalemia, we will find ST depression in the ECG. And for MI, we will find ST elevation. Myocardial infarction, we will find ST elevation. So hypokalemia, ST depression, and myocardial infarction, ST elevation. Now our next topic is cardiology is finished, and our next topic is CNS, Central Nervous System. So what is epigenesis? Epigenesis is found in the axon hillock. Sodium channels open at minus 45 MV. This is known as the firing level. When the sodium channels open, sodium will enter. This is known as depolarization. So at resting membrane potential, there will be depolarization at minus 55 MV and sodium will open. So at spike, now it is going to spike. At 35 millivolt, it is going to spike, and here the sodium channel closed. So sodium channel open was known as depolarization, and now at spike the sodium channel closes. When the sodium channel closes, the membrane again returns to RMP. So the membrane is again returning to resting membrane potential. Now how the membrane is returning to resting membrane potential? It is with the help of potassium. So potassium channel brings the membrane to resting membrane potential, and it is known as repolarization. So this side the sodium channels open, it is known as depolarization. It is going to spike at plus 35, and again it is going to repolarization with the help of the potassium channel. Erlanger-Gasser nerve fiber classification. So what are those? Nerve fibers are of three types: A, B, and C. A is a thick myelinated nerve fiber. B and C are autonomic fibers. A fiber has fastest speed, and the function is somatic, sensory, and motor function. B is a thin myelinated, and it is a slow conduction fiber, and it is present in the preganglionic region. C is unmyelinated. So both A and B are myelinated. A is thick myelinated, B is thin myelinated. C is unmyelinated, and it is the slowest. Okay, it is present in the post-ganglionic region. What is the function? Slow pain and temperature. Slow pain means the visceral deep pain inside our body. Example, what are the examples of visceral deep pain? Angina or headache or colicky pain. Now, A fibers are again of four types: A alpha, A beta, A delta, and A gamma. So A alpha, the function is, it is present in the motor neuron, and it does all type of contractions. So all type of contractions by A alpha. A beta, sensory, only touch and pressure. A gamma is for motor, and it maintains the tone of our body. A delta is for fast pain and temperature. Okay. Now coming to various receptors. So the touch receptors are the Meissner receptors and the Merkel receptors. Merkel receptors are used in 2-point discrimination. Meissner receptors are used in low frequency vibration. So they help to understand low frequency vibration. Meissner for low frequency vibration and Merkel for 2-point discrimination. Pressure and high frequency vibrations are understood by Pacinian corpuscles. For cold, it is the cross end bulb. Hot sensation is understood by Ruffini endings, and pain, temperature, and itching are understood by free nerve endings. These are very, very important. You have to remember all these receptors. Now, coming to the sensory fiber classification. So sensory fiber classification is of four types: 1, 2, 3, 4. 1 includes 1 alpha. Okay, so let's start with 3 and 4. 3 is for first pain. First pain we have already discussed. First pain is for A delta. So 3 is first pain, A delta. 4 is slow pain. Slow pain is also we have discussed. Slow pain is for C. So 3 and 4 are over. 3 is first pain, which is A delta. 4 is slow pain, which is C. Now coming to 2. 2 is for pressure and vibration. Okay, and 1 is 1A and 1B, again divided into 1A and 1B. It is mainly A alpha. 1A includes the muscle spindle, 1B includes the Golgi tendon fiber. What is the function of Golgi tendon fiber? It sends the tension. And what is the function of muscle spindle? It sends the length. So 1A is muscle spindle, it senses the length, change in length, and Golgi tendon fiber, which is 1B, it senses the tension. Now coming to EEG. Okay, EEG, these are rhythms, sleep rhythms. Okay, alpha rhythm is 8 to 12 waves per second, and it is found in light sleep and drowsiness. Beta rhythm is 16 to 60 waves per second, and it is found in active conditions and arousal conditions. Delta waves are 1 to 5 waves per second, and it can be found in tumor or epilepsy or increased intracranial pressure. Theta waves are 4 to 8 waves per second, and it can be found in children less than 5 years of age. What are the two types of sleep? REM and non-REM. REM means rapid eye movement, non-rapid eye movement. In rapid eye movement, the eyeball will move during the sleep The dreams which we see in such type of sleep are remembered, so we can remember the dreams. Muscular twitching is present and it comprises 30% of our sleep. Whereas in REM sleep, in such sleeps eyeball doesn't move. The dream which we see in such sleep, we forget the dream, muscular twitching is absent, and it comprises 70% of our sleep. So 70% in REM sleep is the maximum sleep. What is upper motor neuron and lower motor neuron? So if there is injury in the upper motor neuron, it means there is a tract injury, pyramidal tract injury, and it will result in spastic paralysis. The tone of our body will increase, hypertonic, and there will be no muscle wasting present. Babinski sign will be positive. And in lower motor neuron lesions, there will be flaccid paralysis. It is a nerve or muscle injury actually. Upper motor neuron is a tract injury. Lower motor neuron is a nerve or muscle injury. Upper motor neuron, there is spastic paralysis. In lower motor neuron, there is flaccid paralysis. In upper motor neuron, there is hypertonic. In lower motor, there is hypotonic. In upper motor, there is no muscle wasting, whereas in lower motor, there is muscle wasting. Upper motor, Babinski sign is positive. Here, Babinski sign is negative. So, what is the Babinski sign? Babinski sign means there will be dorsiflexion of the great toe and fanning of the other toe. So, our great toe will be dorsiflexed like this, and the other toe will be fan. So, these things, the dorsiflexion of the great toe and the other toes will be fanning. So when we stimulate the baby's infant's soul, we will find that. So it is present physiologically in infants and deep sleep. So in deep sleep, if you stimulate someone, you can find Babinski sign, and in infants also we can find, but that is physiological, no disease is present. Whereas pathologically we can find it in upper motor neuron lesions. Here I already told you Babinski sign is positive. So in upper motor neuron lesions, we will find it pathologically. Now coming to the spinal cord extends from the foramen magnum to the first lumbar vertebra. The length is 45 cm in males, 43 cm in females. Now there are ascending tracts and descending tracts of the spinal cord. So ascending tracts are what? They are the lateral spinothalamic tract, which controls our pain and temperature, and anterior spinothalamic tract, which controls our itching and crude sensation. What is the function of dorsal column? So dorsal column function is all except these functions. All others like fine touch, proprioception, 2-point discrimination or vibration. Now coming to the descending tracts. So descending tracts can be divided into pyramidal and extrapyramidal. Pyramidal controls all our voluntary movements. It can be divided into lateral corticospinal, which comprises 80%, and ventral corticospinal, which comprises 20%. Lateral corticospinal function is like lateral corticospinal are the ones which decussate at the medulla, whereas ventral corticospinal are the ones which decussation occurs at the spinal level. Now, extrapyramidal can be of 4 types: reticulospinal, vestibulospinal, tectospinal, and rubrospinal. The functions are given here. For reticulospinal, it is voluntary, reflex, and muscle tone. For vestibulospinal, there will be muscle tone, posture, and balance. That is vestibulospinal will control our muscle tone, posture, and balance. Tectospinal will control our head during visual and auditory response, and rubrospinal will control our flexor muscle tone. Now, what is the function of medulla? So, in medulla, we will find respiratory center, inspiratory and expiratory respiratory center. We already discussed in the respiratory system that the pacemaker is pre-Borginger complex. Vasomotor center will be present, which controls our BP and heart rate. Degglutination center will be present in the pharyngeal and esophageal stage. Vomiting center is present, which will induce the vomiting, and superior and inferior salivary nucleus is present, which controls the secretion of saliva. What is the function of pons? Pons is a pneumotaxic and apneustic center for respiration. Function of midbrain. Midbrain consists of 2 parts, tectum and cerebral peduncle. Tectum's function is center for light and auditory reflex. Cerebral peduncle controls our muscle tone. What is the function of thalamus? Thalamus is the center for integration of sensory impulses, and it is also the center for sexual sensations. What is the function of hypothalamus? It controls the secretion of anterior and posterior pituitary hormones and adrenal cortex, medulla. Also, it controls our ANS, heart rate, BP, temperature, satiety, the feeling of hunger or the feeling of fullness, water balance, sleep, wakefulness, everything is controlled by hypothalamus, and also secretion of hormones. Cerebellum, it is of 4 types: vestibulocerebellum, spinocerebellum. You can read the functions from here. Okay. Now, cerebellar cortex, this is very, very important. So, cerebellar cortex, motor area is 4 and 6, which controls our movements. Primary sensory area for sensation is 3, 1, and 2. Broca's area is 44 and 45, which controls our motor speech. Wernicke's area is 22, which controls the comprehension of language. So, We speak through Broca's area 44-45 motor speech, and when someone speaks, we understand the language and understand the speech by Wernicke's area, which is 22. If Wernicke's area is destroyed, we cannot understand the speech. If Broca's area is destroyed, we cannot speak. Now coming to our last topic, which is GIT. In GIT, there are 4 layers: mucosa, submucosa, muscularis mucosa, and serosa. Serosa layer is absent in the esophagus. So serosa is absent in the esophagus. Auerbach's plexus. So there are 2 types of plexus, Auerbach and Meissner's plexus. Auerbach plexus is present between the middle circular and the outer longitudinal muscle. It regulates our GIT movements. Meissner's plexus is present in the submucosal layer. It regulates our GIT secretions. Saliva volume is 1 to 1.5 liter of saliva is produced per day, and it is produced maximally by the submaxillary gland. 70% is produced by the submaxillary gland. pH is 6.35 to 6.85. Digestive enzymes are salivary amylase dialin and lingual lipase. Also, potassium iodide, thiocyanate are excreted through saliva, and it contains the highest concentration of potassium. What is the function of stomach? Stomach contains chief cells which secrete pepsin and prorenin, and parietal and oxyntic cells which secrete HCl and Cassel intrinsic factor. The pH in the stomach is 0.9 to 1.2, which is highly acidic. Digestive enzymes are pepsin, gastric lipase, and other gastric enzymes. Pepsin is secreted by the chief cells, which helps in protein digestion. Gastric lipase are used for lipid digestion. HCl is secreted by parietal or oxyntic cells. Gastrin. And what is the function of HCl? It activates pepsinogen into pepsin. So converts pepsinogen into pepsin. What is the function of gastrin? Gastrin is secreted via G cells in the pyloric part of the stomach. The action is it stimulates secretion of pepsinogen and hydrochloride. It increases the stomach motility, it increases the pancreatic secretion, and it increases pancreatic hormone production. So all these are function of gastrin. Pancreas is both an exocrine and endocrine organ. There are 3 types of cells: alpha, beta, and delta. Alpha cells secrete glucagon, beta cells secrete insulin and amylin, and delta cells secrete somatostatin. Serum amylase and lipase level usually are not elevated in chronic pancreatitis. So in chronic pancreatitis, let me highlight it, chronic pancreatitis, what is the most sensitive method for assessing pancreatic function? It is secretin stimulation test, not serum amylase and lipase. They are not usually elevated. By doing secretin stimulation test, we can assess the pancreatic function if there is chronic pancreatitis. What is the function of duodenum? It is the principal site for iron and calcium absorption. Iron absorption occurs through DMT1 in the apical side of enterocyte, and iron absorption through ferroprotein in the lateral side. So iron absorption occurs on both the sides. On the apical side, it occurs through DMT1 transporter, and on the basolateral side, apical side through DMT1, okay, DMT1, and on the basolateral side, the iron absorption occurs through ferroprotein, and this iron is bind with blood with the help of transferrin. So transferrin helps to bind with blood. So DMT1 on the apical side, ferroprotein on the basolateral side, and binds with transferrin. GIT movement. What are the varieties of GIT movement? Segmentation, which is the pendular movement for mixing of food in our small intestine. So segmentation occurs in the small intestine. It is the mixing of food. What is peristalsis? It is the pushing for food ahead. Haustrations, we can find haustrations in the large intestine, and it is used for maximum water absorption. Mass movement means mass movement is the movement in which defecation reflexes occur, and it is due to the increased pressure. So when the pressure increases by 20 to 25 cm H2O, there is mass movement and we defecate. Okay. MMC, migratory motor complex, it happens during fasting condition, and it is due to motilin. MMC, migratory motor complex, let me highlight, it occurs due to motilin. And what is the intestinal pacemaker of the cells? It is the interstitial cells of Cahal. So with this, we end the must know topics, a quick rapid revision of physiology. You will get almost 90% of questions from this topic. So more than 12 to 13 marks you can expect in your exam. From more than 12 to 13 questions in the FMGE and NEET PG exam you can expect from this PDF. If you need the PDF, the link for that will be given in the comment box. It will be pinned in the comments. Also join the Telegram group, which the link will also be given in the Telegram, like the comment box. You join the Telegram group, for which you will get all the updates for the upcoming videos, and it will help you boost your preparation. Thank you. Have a good day.